So let's start our Future Office Advanced webinar series on quality, affordability, and accessibility with the Affordable Care Act. Here's our agenda for what we're going to cover in the next hour. Number one, steps to take right now that your organization can do to expand and preserve health benefit coverage. Number two, what to do in the transition period applicable to group health plans. Now, the transition period is not really defined there, so allow me to define that for you. The transition period began when the law was signed by President Obama, and that was on March 23rd of 2010. And the transition period goes through the 31st of December of 2013, basically New Year's Eve later on this year. That's the transition period, and in the law, the way they talk about that and sort of the purpose behind that is as you probably have all figured out, this is sort of a work in progress. And so during the transition period, Health and Human Services, the Department of Labor, Treasury, they're issuing the rules and the model notices and the things. And of course, that's why we're having so many of these webinars to keep everybody up to date. But that's the transition period. Number three, in terms of our agenda, what coverage improvements are going to go into effect on January 1, 2014 for employer-sponsored health benefits, the benefits that you currently offer your employees. Now, there's some new reporting obligations. Hopefully all of you, if you have 250 employees or more, did fill in on the W-2s of the employees section, the boxes, 3 boxes actually, 12A, 12B, 12C. And that had to be done by the end of January. And that was the first time ever in history that we've had to actually report the value of health benefits that we as employers provide to our employees. But that was an obligation from last year, and we're water over the dam on that. The last piece that we're going to talk about is the additional electronic transaction standards, which I must admit is not very exciting stuff. And the good part is that it's very, very short. So I do urge you to at least sit through that part. Maybe it'll be of value to you. Maybe it's not something that you'll have to deal with. But the good news is it's the shortest piece of everything that we're doing here. Well, I'll tell you what, we're going to start off with a quick poll here. We're going to check you and see what your thought is on a poll. So here we go. Is your organization in compliance with the Affordable Care Act as of January 1, 2013? Is your organization in compliance with the Affordable Care Act as of January 1, 2013? And the numbers have come in. We'll let this go for just a few seconds, and then we'll tell you what everybody had to say. Okay, we have 100% voted, and the results are 38%. My, 38% of you said that you're in compliance with the Affordable Care Act as of the first of the year. 0% said no, but probably the really big statistic here is that 62% don't know if they're in compliance. And that is really why we're doing these things, because I think there's, well, if you read the polls out there, people do not understand this. So we'll be doing a couple other polls just for the fun of it, and as we go along here. All right, steps to take right now to expand and preserve health benefit coverage. Now, this is stuff that is taken right out of the law, and what I'm going to do is, at times I'm going to read the material. I know for those of you that look at this, some of this isn't great PowerPoint material because it's so much text. But I opted in drafting this to say, well, this is something we can give you You can print this out, and it's the real deal, and you'll have a record of that. But there are a couple things in here that are no longer current, and I'll be sure to point that out for you, so you don't go ahead and try and doing that. Number one is the high-risk health insurance pool to provide health insurance coverage for eligible individuals beginning in 2010, which will end on January 1 of 2014. Okay, that 2010 actually precedes the signing of the law, so it was retroactive back to January of 2010. Law was signed on March 23rd, and it goes through until the rest of this year, and we'll have a wonderful New Year's Day on January 1. Now, the high-risk health insurance pools, the individual states, for example, I'm in Wisconsin, and in Wisconsin we have 2 pools that sort of mimic this high-risk health insurance pool, and I'm going to use those as an example to explain what this high-risk health insurance pool is. One of them is called Badger Care. The other one is called HRSP, High-Risk Insurance State Pool. I think that's what it's called. And what it is it's for people that have been turned down by insurance companies or stop-loss carriers in a self-funded plan because of their poor risk characteristics. And primarily what we're talking about there is that they have some pretty nasty pre-existing conditions. So what happens is they then go into a special form of underwriting in these high-risk pools, and they're sponsored by the state. In this case, we're talking about one sponsored by the federal government. And that's for people that fall between the cracks because the current law, the current statutes, as we know, for anybody older than 19, right now as we speak, pre-X does apply. And of course that affects a number of people. We have a person in our office here that falls into that situation, and it's kind of a nasty deal. Now the high-risk health insurance pool will terminate as of January 1, 2014. And the reason is because at that point, pre-existing conditions, right now they're 19 and under. There's no more pre-X, and that was September 23rd, 2011, I believe. So adolescents and children can't apply pre-X. Adults, yep, we can apply pre-X right now. January 1, none of your plans will be able to apply legally pre-X, pre-existing condition clauses against anybody that joins the plan. Okay, point number 2, the temporary reinsurance program to provide reimbursement for employer-sponsored group plans for a portion of the cost of providing health insurance coverage to early retirees. That program is going to end on January 1 of 2014. Why? Because we're pretty much going to have a universal access across all age groups, from the newborn to some of the oldest and wisest of our population. And so that's what that means. Right now there is a reinsurance program. It's financially not doing very well, so you don't hear too much about it, but it does exist, and it's to help people who are retiring early to kind of bridge over into Medicare. And so that program will be terminating on January 1. So if you have people that are in that kind of category and they're taking advantage of this, and something tells me most of the people here don't have anybody in there, because it hasn't been a very popular program. But if you do, there's a communication opportunity for you to tell them that that is going to terminate. And well, let's assume that maybe they're more confused than maybe some of us about sort of the ins and outs of the Affordable Care Act. So there might be an element of fear, is my point. And so it'd be a good idea to put them at ease that even though that's going away, their coverage is actually going to be in place there at that time. Number 3, take advantage of the small employer tax credit to subsidize part of a small employer's cost of coverage for employees. Now, that was one of the first things out of the box, and Health and Human Services, along with the DOL and along with Treasury, put that together. My experience has been in working with a lot of employers, and these are smaller employers, is that there were so many hoops to jump through that by the time you answered all the questions, what seemed to be like a really great program ended up with either no credit or a very, very small tax credit. So that might be something you also have not heard about a lot of late, because that came into play in 2010. And it was all the buzz back then, but it quickly kind of died off because employers go, well, it sounds like a good thing, but when you work the math through, it really doesn't do anything for us. Number 4, an internet portal through which a resident of any state may identify affordable health insurance options in that state that they reside, including Medicaid coverage, any high-risk pool, so people that have some rather bad health conditions and right now pre-existing condition clauses are hurting them. They're in that high-risk pool offered by the state or the new federal high-risk pool. That's part of the Affordable Care Act. Now that internet portal, they're behind on that. That has really not come to fruition. So that's one of the pieces, I guess, in the interim coverage that hasn't quite worked out so well just yet. All right, apologize for this busy slide here, but it's just a lot of good information for you. What to do in the transition period applicable to group health plans. Number 1, a prohibition on lifetime or annual limits on dollar value of certain benefits. Well, one of the certain benefits that they're speaking there of is mental health. Now, the Mental Health Parity Act of 1996, which was had sunsetted in I believe it was 2000, it's still around. It's just been Congress they do that with some benefits, and it currently is alive, and it's known as the Paul Wellstone substance abuse mental health parity. You got kind of a long, but it's the Mental Health Parity Act, and here's what that law says, just in case you don't know what it is. The Mental Health Parity Act says that if a group health plan has annual or lifetime limits on non-mental health benefits, then the same or better limits must be put on mental health. Now, come January 1 of 2014, there will be no discrimination between benefits. And so when they're talking about a prohibition on lifetime or annual limits on the dollar value of certain benefits, it's actually all benefits. It's just that not all benefits have this kind of a problem right now, and that's why they say certain. So the benefits such as mental health, where there currently is some inequity, not on the annual lifetime limits, but there's other inequities between the benefits. Those things are going to go away. They're going to go away. So we're going to have pretty much all mental and physical health care and some other types are all going to be treated the same. Number 2, a prohibition on pre-existing condition exclusion provisions for children under 19. Well, that's old news because that has been in effect for some time, and that's that. Minimum preventive, point number 3, minimum preventive health services coverage requirements without cost sharing by the enrollee. All right, one of the things that the Affordable Care Act is going to do is make plans more uniform. And part of that uniformity to provide affordable care, because that's a big part, it's one of the anchors in the Act, is to to reduce cost sharing or eliminate cost sharing for the enrollees in the plans. So the reason that we have it in right now, the transition period, is that this is going to be something that will be required of you, of your company, of your organization, come January 1 of 2014. So kind of get ready for that now because it's going to hit you. You might want to amend your plan effective for whatever your renewal date is on January 1 or later. The extension of coverage for children until age 26. Again, old news. That's been out for a couple years, and that's that. Requirements for an appeals process of coverage determinations and claims that must include, at a minimum, an internal process and an external process that is binding on the plan. There's a lot of stuff that is in between the lines on that particular requirement. One of the things is some of you may have heard of these things called death panels. When we were all in the height of the election season, going up to the presidential election, you know, there was just so much stuff flying around, and some of you might have caught wind of when one of the parties would talk about health care, you know, that grandma's going to be taken off of her life supports because she's too old. You know, this kind of thing. Now, truth be told, there are some, I guess the truthful term is there is some rationing of coverage based on age that's couched in the language of what is necessary treatment for an individual. Now that, if you've got somebody who's an elderly mom, dad, a grandparent, you know, that might give you cause for concern. There's a few other areas that, because the Affordable Care Act is different from what any of us have had for health care up until when this kicks in on January 1. Congress has put in this appeals process for coverage determinations. So, you know, there will be a process that if you or a loved one, and you on behalf of a loved one, says that, you know, I don't think this person is getting the proper coverage, or a claim isn't being handled properly, these kinds of things. Problems with the actual physical care of the patient, you can appeal through this process, which is at this point just words, but it is going to become a real thing with real people and real phone numbers and real ways to get access to them. But that's really what that's all about there. So it's kind of a safeguard for all of us of things that may either have been legislated and we want to appeal because we didn't think it's correct and it violates some other civil right or a law or something like that. Or the law of unintended consequences, which is always a problem with something of this size especially. The law of unintended consequences. So something by omission that was not put into the Affordable Care Act could cause a problem in practice, and therefore you need an appeals process to do that. So this is a very, very, very good thing. Next point, restrictions on rescissions of plan coverage of an enrollee other than for fraud or intentional misrepresentation of a material fact and subject to notice of cancellation. Basically, what's going to happen here, and we're talking about it today, probably more important talking about it in the summer, but as we go into the fall period, your plans will have to be amended so that you cannot have a rescission of plan coverage. You can't take something away willy-nilly. Now, that's not to say that people do that today, because as you know, there are rules for what you can do and cannot do once a plan is in effect, particularly a 125 plan. But nevertheless, they're putting this rule in here for a reason, and that is to give some comfort to people that as this cathartic process runs its course, going from sort of the old way of providing health care to the new way of providing health care, that during that period of time, it is restricted that plan sponsors or the exchanges cannot rescind plan coverage of an enrollee unless it's a fraudulent deal or an intentional misrepresentation of material fact. Okay, the next bullet, second last bullet here. A required standardized summary of benefits and coverage to be provided to applicants, enrollees, and policyholders. Have you noticed, by the way, just as a kind of a sidebar here, that we talk synonymously about group health care coverage and individual coverage. That's a particularly profound statement. Individual coverage does not have the protections of, say, COBRA. Group coverage does have, as long as you have 20 employees, has a protection of COBRA. One can speculate that maybe we're not going to need a COBRA anymore, or it's going to, something like that is going to be expanded to individual health care coverage as well. Group and individual coverage are going to start to look like one. So let me read that one more time. A required standardized summary of benefits coverage. That, by the way, is called the SBC. And that's to be provided to applicants, enrollees, and policyholders prior to enrollment and upon renewal of coverage. Now, let's talk about that SBC, because that's actually been out for a number of months. And for those of you that are on Future Office Network, you can just go right into Future Office Network, and there's two search engine boxes on there. Just type in SBC, and it'll bring it right up. The SBC is like an SPD. The summary of benefit coverage is like ERISA Title I summary plan descriptions. Summary plan descriptions under ERISA are still the law of the land. You must provide, whether it's an insured or a self-funded plan, a health plan that is actually other benefits as well, but we're talking about health in this particular call. Anybody that's on the health plan, dependents, employees, they must receive a summary plan description, an SBD under Title I of ERISA. That's been around since 1974. We all know that. We also know that if you have an insured plan, and if you're a smaller employer, that you may not recognize that SPD because perhaps you as an employer have not done it, and you've deferred to the health insurance carrier to provide the SPD, but they have not done it. This is true, and this is a problem. So there's a fairly mass non-compliance on this issue. Now, talk about the SBC, the new piece in the Affordable Care Act, excuse me. The SBC is duplicative in some parts of the SPD. So some of the SPD and the SBC, in some things, they both cover the same thing, but they also both cover different things. Now, we have not seen anything that has come down the pike from the government in terms of, is the SPD just going to go away? Because we certainly have heard a lot about the SBC. And, you know, nothing has been said. So for right now, it seems kind of maybe a little silly. But you do have to provide an SPD to your plan participants. And you do have to provide an SBC. Now, the SBC, it is a structured, formatted document. It is unlike an SPD, which has labor regulations that say, okay, it has to include this, that, and the other thing. The SBC is like a fill in the blanks. That's a much easier tool. And you fill in the blanks, and you give that to applicants, enrollees, and policyholders prior to enrollment. So what a lot of people are actually doing in practice is if you use an online enrollment tool, you put that right at the very beginning. At the very beginning. So it's technically prior to the enrollment. It's maybe seconds before the enrollment, but they're going to get it at the beginning of the process. Now the summary of benefits coverage, the SBC, must also be accompanied by another document. These always go together. The SBC must be accompanied by the Uniform Glossary of Terms. The Uniform Glossary of Terms. And what that is the government has seen fit that the lexicon of health plans has become so complicated that employees perhaps don't always understand a lot of these crazy terms, formulary and three-tiered this and co-pay and co-sharing and premium co-sharing and co-insurance, and you get the idea. So they have mandated, HHS has mandated that the summary of benefit coverage, which is like what the plan actually covers in very simple terms, it's a pretty good document. That has to, because it uses the language that is part of the ethos of healthcare, that must be accompanied with the Uniform Glossary of Terms. So always just kind of keep those two in mind, that they both go in tandem. They both go in tandem. Last point on this particular slide, a prohibition on eligibility rules for insured group health plans that have the effect of discriminating in favor of higher wage employees. Okay, that is currently on indefinite hiatus. That rule is on indefinite hiatus. That's not to say it's not going to come back at some point, but that rule, you don't have to worry about it. Let me explain. Insured group health plans are sanctioned under Section 106 of the Internal Revenue Code. That's it. You look up Section 106, you'll see some stuff, but basically they're talking about insured group health plans. They talk about some Archer MSAs and some other things in there as well, but that's the law. That's the part of the tax code that gives employers the right to offer insured group health plans without incurring a tax liability for the employee or for themselves, the employer, that is. Now, the rules under Section 106 of the tax code are more lenient than the rules of another section of the tax code called Section 105H, small h. Section 105H is the part of the Internal Revenue Code that applies to self-funded plans. And there are basically three non-discrimination tests within Section 105H. Back when the law was first conceived, the rule was that in 2011, all insured plans had to convert from being governed under Section 106 of the code, specifically for these non-discrimination tests. And they were going to move them all to Section 105H. Okay? Now, the numbers, you can forget about this afterwards. Just remember that there was one code. They were going to try and say, well, that's not going to be the code that governs insured plans anymore. It's going to be a new section. And that new section has more stringent non-discrimination rules so that the plan cannot be set up to favor highly compensated employees. And that's the actual term, highly compensated employees, HCEs. Well, as you might imagine, for small employers and large employers alike, that was a pretty big deal. And so the pushback was intense. HHS got the pain, and they said, they came out with a ruling. They said effective immediately. 105H rules for insured plans are no longer required, and that basically threw us back to how we've been running a plan, an insured plan, all along. So that was a fairly long discourse that I just gave you there about that particular point, but I wanted you to understand what the full intention is of Congress, and that trying to sometimes make these things happen, we have a lot of people that can really push back a lot politically, and that's pretty much what happened on this code issue here. You may have some questions on that, and if you do, just raise your hand, and I'll take them when we get to that point. Okay, let's do another poll and see how we all feel about this. Here's the question: will your organization continue to offer employer-sponsored health benefits after January 1 of 2014? Will your organization continue to offer employer-sponsored health benefits after January 1 of 2014? Boy, this is a scary question, scary answers. And we're tabulating the results. 93% have voted. A couple people haven't voted yet. Go ahead and vote. Okay, we didn't get everybody, but we have 93%. And here is the results. %46 said, yes, we are going to continue offering employer-sponsored health plans after January 1. So you're not going to be affected by the exchanges. You're going to keep on keeping on. And 15% said, no, we will not offer employer-sponsored health insurance. Now, that could mean two things. One, you're not offering it now, or two, you're offering it now, and you're going to cease offering it in 2014. 38%, again, another big number here, the uncertainty factor on these questions is high. 38% said, I don't know if I'm going to be providing this in employer-sponsored health benefits in 2014 as of January. So that's that one. Okay, what coverage improvements go into effect on January 1 of 2014? Some of these we've kind of covered a little bit, but I guess maybe saying it twice doesn't necessarily hurt. Number one is prohibitions on pre-existing coverage exclusions for adults. Boy, that's going to be a welcome thing. There's so many people, we probably all know somebody that has a chronic ailment that they can't get covered. And yeah, it's more expensive, but boy, from a public policy point of view, it hurts people that you know that are stuck in that situation. Well, come January 1 of 2014, that will no longer be the case. Nobody will have to be locked into a job because they can't change health care coverage, even though HIPAA has a rather elaborate and fairly good scheme for how people can move and not lose and not be subject to pre-existing conditions. But anyway, it's going to be gone. January 1. No pre-X. That word is going to be knocked out of the dictionary. Number two, underwriting of premiums for insured coverage limited to certain ratios for age and tobacco use. Now, this is very much tied into the whole concept of wellness. Wellness is a big part of the Affordable Care Act, big part. And there are incentives and grants available for companies that want to set up wellness programs. And we all know that we tend to get more ailments, and we get sicker, and as we get older, that's just a fact of life. But tobacco use is not. And we also know that tobacco is a cause of so many deadly diseases, and it does, in fact, cut your lifespan shorter, period. So age and tobacco use are going to work against an individual who is in the latter stages of life, and or a person who is using tobacco. Even though that is a lawful product, There are laws that say you can use lawful products, but we also know that tobacco is the #1 cause of lung cancer and all kinds of crazy things, terrible things. So underwriting is going to affect that, and that means that people that are older, now if you're individually underwritten now, and age is going to work against you anyway, so I'm not quite sure what that means there. But tobacco use, they're going to actually make that as a requirement that we know that information before we underwrite what premium the employee or dependent who uses tobacco is going to get. It's going to cost more for people that smoke. Number 3, guaranteed availability and renewability of coverage by all insured plans. All right, so that means that you cannot be kicked off of your insured plan. You will automatically have it renewed. You will not have to worry. You can tell your employees they will not have to worry about, number 1, being able to get on a plan because there will be guaranteed availability. Number 2, once they're on a plan, nothing can really happen to them that would cause the carrier to be able to not renew them and hence cut short their health care coverage. Number 4, prohibitions on discrimination and benefits against individual participants and beneficiaries based on health status. There's a concept called lasering. It's an inside shop kind of a term, and there's some other ones that are kind of like it. But basically, you as employers may have seen this in your organization where your broker, your consultant has come to you and said, well, you know, we've got this insurance company out there, and they'd love to write your policy and write your benefits here. But, you know, remember, they always came to you and they said, are you aware of anybody that is really sick in your population? And you have a legal duty to tell them, and I'm sure all of you do, you have a duty to tell them if you are aware that somebody is really, really sick in your population. If you're unaware, you say, no, I'm not aware. And that's perfectly legit. And even though there might be somebody who's really sick, if you're not aware of that, you have cancer or something, but you're not aware of that, well, then you say, I'm not aware of it, you know, nobody's going to know. But if you are aware of it, you have a duty to tell the consultant or the broker who's going to write that and carry that information, and they will convey that to the insurance carrier. Well, on January 1, that's going to be changed. It will be unlawful to discriminate in benefits against individual participants based on health status. So if somebody's got a bad case of diabetes, which is a terrible illness, or if somebody has a heart condition and they've had stents, and we know that they're just not well. Well, they're not going to be able to single those people out anymore. They cannot be discriminated against benefits relative to the general population that is being covered. That's going to be very welcome news for those people. The downside, I must tell you, is that it's going to cost more, because that an insurance company is going to have to write that up, because that risk represents a higher risk and therefore a higher cost. But for the beneficiary, it's pretty good news. Annual cost-sharing limits for comprehensive benefits. Not sure what that all, I mean, I understand the concept, but not sure what that all means, because they haven't told us what that is yet, what those comprehensive benefits really are. Prohibitions on discrimination against healthcare provider participation. Currently, PPOs, HMO panels, EPOs, all kinds of flavors like that, the medical community, carriers can play certain games, things that really work in the benefit of the carrier, and they may say it works in the benefit of you, the employer, and all of that may be true, but that's not necessarily good for the healthcare provider. So they're trying, the law here is attempting to even the playing field. And so this prohibition on discrimination against healthcare provider participation is just that. If a healthcare provider meets certain, if they're board certified in their particular thing, and that means they can then practice in a hospital, or whatever standards are applied in the medical community, as long as a healthcare provider meets that standard, they can be admitted in, and you can go see that person. So that's going to kind of break down this PPO panel, can't go out of the network and I'll have to pay a fortune if I do. That's all going to be kind of, those rules are going to be loosened under that particular point. No waiting periods in excess of 90 days. Well, traditionally we've had like probably 30 days in your plan. Maybe it's like, you know, the first, you hire a person, here it is the middle of February, and you say, well, it's 30 days and then the first of the month, or whatever it might be. Those are ERISA rules. Those are ERISA rules. Now, there's a new rule here that supersedes ERISA, and that is you cannot have a waiting period in excess of 90 days. It's a longer time. Now, actually, under ERISA, you can keep people off of a plan for much longer than that, but I've never seen a plan that does that, because who in the world would be able to attract and retain a qualified employee if they had to sit off for a year? So on one hand, they're making this longer, but under the law, they're actually making it less. So it's 90 days. That's the maximum waiting period that you can make somebody sit out before they actually are available to actually engage in the plan. Last point on this slide, coverage of medical services in clinical trials. For a lot of people, this is really, really important news. This one kind of hits home, and I'm not going to go really deep into this here, but I almost lost my wife last year. She was given 3 to 4 months to live. She had a really rare cancer. We heard the words that nobody wants to hear, and that is, there's nothing we can do for you. Go home and get your affairs in order, which is what they told us in December of 2011. Good news is that my wife is perfectly healthy today, and it was a miracle. It was just a miracle. But through that whole process, we were exposed to clinical trials that were way beyond experimental. They're almost ready to be approved, but they're not quite approved yet. And insurance companies have waffled on those kind of things and usually turned it down, saying, you know what, we're not going to pay for an experimental. Well, it's not exactly experimental. It's a little bit farther along than that. Well, effective January 1, all of us will have coverage for medical services in clinical trials for those strange things that maybe we never quite get better in a clinical trial for a new drug or a new procedure or something like that could help us. Okay, let's do our very last poll here, and we're not done yet, but okay, here we go. Here's our question. Does your company currently offer benefits to single contracts at a cost of pardon me, let me start it again. Does your company currently offer benefits to single contracts at a cost of 9.5% or less of the employee's annual income? Let me read that one more time, because it's kind of a lot of words moving around there. Does your company currently offer benefits to single people, single contracts at a cost of 9.5% or less of the employee's annual income? 9.5% is the magic number because affordable care, the Affordable Care Act, the word affordable means that the plan cannot cost more than 9.5% of an individual's annual income. Okay, we've got roughly half the people have voted here. We'll just wait for everybody to kind of weigh in on this particular score. Thank you for doing that. And we're almost done here. Okay, with 93% of the vote in, here is your results. 46% said, yes, we currently offer our plans to single contracts where the cost is 9.5% or less of their total compensation. Good. You are in compliance already with the law. 31%, however, roughly a third, say, no, we do not. That means you are offering an unaffordable plan. And I'm sorry to be the bearer of bad news and don't shoot the messenger, but that's going to cost you. So you're going to have to do something to bring your costs down for those employees. 23% of you don't know, and I don't blame you. That's the kind of thing you necessarily rattle off the tip of your tongue. I haven't analyzed that kind of thing. But those are the numbers, and that's an interesting question. Okay, prohibitions, we've covered all these pieces here already, so let's go to the very last slide that we have here, and we'll take some questions here. Again, I apologize, a lot of words here, but I opted to give you something that you can print out and look at for reference. The new reporting obligations. All right, to facilitate the introduction of the web portal for consumers as of July 1, 2010, I think that's healthcare.gov, so don't misunderstand or don't misconstrue that with the health exchanges, because those are different things. But that's when insurers were required to submit plan background information to HHS and more specific pricing and benefit information. Didn't exactly really happen, but it was a good thought, I guess. Beginning in 2012, last year rather, insurers were required to report on the percentage of total premium revenue that is extended on clinical service, healthcare quality improvement, and non-claims costs. Insurers were required to provide an annual rebate to each enrollee. Now that happened last August. You may remember that in the news. A lot of plans, a lot of insurance companies, they did not meet the mark, and they had to rebate that money to the enrollees. They have to do that on a pro rata basis if the non-claims cost exceeded 20% of the premium for a large group. Now, a large group is 100 employees for purposes of the ACA, and 25% of the premium for small group and individual markets. Okay, so that's something that, unless there's a big rebellion, we're going to hear that for the foreseeable future every year. Number 3, group health plans and insurance coverage will be required to report on their benefits and reimbursement provisions that improve health outcomes, prevent medical error, and improve patient safety and implement wellness and health promotion activities. Okay, that has not happened yet. That information is not being uniformly produced. Number 4, group health plan and health insurance issuers must submit certain information regarding plan design to HHS. I believe that's begun, but that is certainly not anything that has where we can see that yet or see the benefit of gathering that information for the public. The last point, employers will be required to report on employer-sponsored insured and self-funded, says self-insured, I believe self-funded and self-insured mean the same thing. Some differ with me on that, but that's okay. They're required to report on employer-sponsored insured and self-funded coverage to the IRS and to furnish related statements to employees effective for plan years beginning after December 31st of 2013. So don't confuse this with the rule that was in 2012, where you had to report, if you had 250 employees or more, the value of health insurance, or health care actually, on the W-2 of the employees that had to be no later than the end of January on boxes 12A, 12B, and 12C. This is a new rule. The last bullet here is a new rule that you'll be hearing more about. It hasn't been fleshed out in the regulations yet, but there will be more that will come out later on this year for what we have to do at the end of this year. All right, here's the one piece. This is the last slide here, and then we'll take some questions. There's some additional electronic transaction standards. Now, this is really kind of an ongoing thing that really started with HIPAA back in 1996, which went into effect in July 1 of 1997. And that was to have electronic data standards and EDI, electronic data interchange. Basically, what we're trying to do is make, what our country's trying to do here with the healthcare system is make the transmission of financial and claims and everything that's associated with healthcare, pharmaceuticals. If you go to a doctor today, they probably have an iPad or some kind of a tool like a tablet, and they don't write it on that little clipboard that hangs on the door anymore. It's an electronic world, so we're using technology. So we need standards and protection on that data, on that personal health information. So there's some more transaction standards that have been passed in the Affordable Care Act, and that's to advance the financial transactions that will be necessary to implement and operate the exchanges. Now, Health and Human Services also is charged with the adoption of additional uniform standards and business operating rules under HIPAA. So we're going to take another whack at HIPAA. Now, just recently, in the last 30 days or so, I think it's even the last 2 weeks, there have been some new final rules on HIPAA and high tech. And HIPAA and high tech go together because they both talk about dealing with personal health information, PHI. Big deal, big fines if you mess up on that. Anyway, it goes on to say that HHS is going to be adopting these new rules under HIPAA for electronic exchange of information by plans, health plans, and with respect to eligibility, electronic funds, transfers, enrollment, disenrollment, healthcare premium payments, and claim-related transactions. When you think about that, for the purpose of an exchange, which is in essence going to be this internet portal that will reside in various different places, it's going to allow all of us, either through a group mechanism or through an individual mechanism, to go and see a bunch of carriers that would want our business and get the pricing on that business, pick a plan, and then do the enrollment all at one time, and it's done. And so these are simply the rules of the road for how that data is going to be transferred securely and to whom it's going to be transferred. And that's really a summation of this particular point here. So with that, I do want to tell you about two things really, really quickly here. First of all, the next webinar in this particular series will be next month, and that's going to be preserving and expanding immediate access to coverage. We're going to talk about small employer incentives. I'll talk a little bit more about pre-existing condition plans because we're anticipating that there's going to be some more information out by then that's not there now. Now, last but not least, I do want to show you something here that's available to the public, but maybe if nobody showed you, you wouldn't have known about it. And let me get up there and show you this here. Bear with me just 1 second, please. www.davidsonmarketing.com. Okay, you might want to write that down, www.davidsonmarketing.com. When you get there, if you click on FONHR, you see there's a pay-or-play calculator here. This is you can download this. It's free. We're not making any money. This is a public service. It's a wonderful tool. It's very simple, very fast. But what it'll do is it'll in your specific situation, you can go and enter the numbers, and it'll tell you right away what your penalty will be, if there is a penalty, and how much it's going to cost you. So it's a wonderful little tool if you're thinking about on the fence, should I pay the government and just dump my people on the plan, on the exchange, or should I mean I'm going to keep my employer-sponsored benefits? So davidsonmarketing.com, click on FONHR, and there it is. Okay, let's look at some questions here. Anybody got their hands up that we can ask questions about, answer questions perhaps? I do have a couple that are written in here. Let me just take them from the way they were given. Okay, Deb, you have a question. Does guaranteed availability and renewability of coverage by all insured plans mean that there is no longer any open enrollment phase or a needed qualifying life plan to add another person to the plan? No, I don't think that's true, Deb. There's always going to be that. If I'm reading your question properly, there's always going to be that what we call a change of status in health and welfare benefits. You get a divorce, you get married, you have a child. These kind of things that change the makeup of your personal unit of people, your dependents. And so I have not seen anything that indicates that that's going to go away. Deb asked another question, and that is, what about fertility treatment coverage? Boy, that's a good one. I'm very familiar with the depth of feelings about that issue. I have not seen anything about any of the different types of fertility treatments being covered by the plans. I've not read anything about that, and I try to follow this thing as closely as I can. And I'm afraid that might be bad news for you, and I hope that's not the case, but that's the answer. Jeff, you have a question. Can you explain how the prohibition on discrimination against healthcare providers will affect carriers like Kaiser and other HMOs? Well, I can take a shot at it, Jeff. My guess is, based on, I've seen other language like this in different state things, is that Kaiser may be required that anybody that meets the Kaiser standards for being a medical provider or a physician, they're not necessarily one and the same, as you know, that they would have to be admitted to the Kaiser panel as long as they have one uniform standard. They can't discriminate. That's clear. Plans will not, insurance companies who have medical provider panels will not be able to discriminate against providers anymore, except for based on qualification. One more question here from Jeff. If the employer offers group coverage to dependents but does not contribute toward dependent premiums, can the dependent go to the exchange and receive a tax credit of the subsidy? Yes. And that was it for the written questions. Let me see if there's any other hands up here, and there are not. So I want to thank you very much for participating. Please fill out the evaluation, and we look forward to seeing you. Invite some friends. We'll have more fun next month as we talk about some other issues on the Affordable Care Act. And if you stay with us all the way through May, our promise to you is that you will have the most up-to-date and as thorough as we possibly can make it information on the Affordable Care Act. And I know the minutia is kind of painful at times, but it's necessary professional information. Have a very good day, everybody, and thank you very much.